So my perspective is from a lived experience family perspective. Always tricky as a family member. You're talking sometimes on behalf of other people's experiences. I have expressed permission to do so. And I guess before I start talking about family perspectives, just want to acknowledge that this is a white middle class room actually. But my perspective is also very, very white middle class, and when we talk about lived experience, really, really keen to promulgate an awareness around our First Nations people's definition of lived experience, which is different and is very much centred in dispossession is a sanitised word. We'll call it atrocity and ongoing racism. And I also want to recognise the expertise of the people with lived and living experience in this room, both individuals with direct experience of psychosis, taking Amanda's point, and of course family members like Barry. Thank you for your amazing presentation. I hope to hear more of it. Okay. And I just want to lean into a little bit some of the perspectives that Amanda was talking to, and this just comes from a piece quite a few years ago now called Relational Recovery, which really does highlight, as Amanda was saying, that we need to relocate our gaze from within the space between people's ears to what's going on around them, because I've discovered that it's a political and ideological space that we're all in. Not particularly scientific or evidence-based, and have been looking for many years now, actually. I thought it would be a simple exercise as a family member coming out of many, many years underwater to really just talk about what it was that we needed. It doesn't work that way. It is a political space, and so I've been exploring some of those barriers towards reform, particularly some of the things Sophie talked to in terms of the lack of there is no evidence to me of intent to change. When you look at the lack of implementation approaches, solid interrogation of change management, which is what we're talking about, of course. So I am going to lean very much into the politics. I should also just highlight that as people with lived experience, neither Amanda nor I are wearing elephant pants. And even though our perspectives may challenge and hackle raise, because, of course, we don't have medical science degrees, we do bring authority, legitimacy, credibility, and don't take too kindly to being infantilised. So we're not Scientologists. We have been called that in the past whenever we raise challenges around the lack of evidence-based, rights-based approaches to distress. I did vaccinate my children, so we do very much adhere to and believe in medical science more generally. It's just that we have been harmed by the mental health system. And so, of course, we tell our truth. Because it's also so-called Carers Week this week, I just wanted to give another example of the politicisation and the dominance of silencing discourses around experiences. And so you're probably very, very familiar with these thought-terminating cliches and the power of language in positioning people, particularly families. So we're often, the unsung heroes, despite the fact that we provide more support than any paid workforce because of the failure of the mental health system. But instead of encouraging family members to resist and work alongside people with lived experience on our journey, mutual journey of emancipation, we are, of course, told that we have to do self-care because, by God, the community and our services won't be doing it for us. So I'm just, again, highlighting the very, very political nature of most of the things that I'll be talking about today. This is a great example of something that didn't make the headlines, that we know actually that the current services, and Sophie alluded to this, are not evidence-based actually. Most of the research that has been done so far is profoundly, profoundly flawed. This was an umbrella review done a couple of years ago now, identifying really because of whether it's flawed methodologies, whether it's, as Amanda alluded to, being seen as objects rather than active participation in the active participants in the research, publication bias and so on. A lot of the so-called evidence that informs our current services, including this thing that we call confidently schizophrenia. Actually, there's really no evidence behind it, and so of course families have become the default support workers in the system. So in the literature, it's pretty clear, particularly from people without a vested interest in maintaining the status quo, mostly from epidemiologists, we really do need a different way of approaching research. Many of you have probably seen this one from Thomas Insel from the States, talking about really not moving the needle at all. We've invested for many, many years in looking at the brain, but actually we've not really done anything in terms of truth on the ground. Ground truthing is actually a concept that's used in other sectors to test the efficacy of models. We don't do it in mental health. So much so, of course, that the Lancet introduced a Commission on Psychoses in a global context, again, very service provider-led. They did introduce some lived experience expertise into this process because they have found, of course, that in high-income countries, we know the reality is that the outcomes for people are very poor, unacceptably, unethically, immorally, outrageously poor. But I've highlighted the fact that it's in the decades after the initial contact with mental health services. This is not an access proposition. Every family member has at some point taken their loved one in distress to a GP, usually, most often through ED as well. We've had contact with services, and as Barry alluded to, the voice of lived experience says they are probably harming us more than they're helping us. This was a reflection of the experience of researchers in terms of the Lancet Commission, finding very much that they've been included, like lots of headlines around people with lived experience now being included in research, but that the experience itself has been one of disempowerment. So we're still up against an echo chamber, a bubble, a paradigm, very much around medicalisation of distress, and that experiences of people with lived experience coming into these echo chambers is usually very, very, very harmful. So we need to do more, and I'm sure Michelle will talk about it later in terms of providing safety for people with lived experience coming into an oppressive knowledge system. On the other side of the line, this is the National Mental Health Systems Commission, report card from last year, identifying, as Sophie said, we actually don't know, out of the 12, 13, however many billion dollars now that we're pouring into mental health, whether or not anything is effective. There are gaps all over the place. I've pushed really hard to get these gaps highlighted, that we actually don't know whether or not the systems are effective. We don't know about the experiences and outcome of people, and we don't know about the experiences and outcome of their families, carers and kin. So we're in the wilderness. We are in the wilderness, both in terms of research and on the ground, and I'm not confident, frankly, that talking about translation, I don't think emancipation is going to be found on the bench or on the bedside. We need a completely different way of looking at these issues. I want to also highlight that out of the fifth plan, there was a national research strategy that was pulled together, former Psychosis Australia trustee pulled together from a service provider perspective, a paper on psychosis. And part of that strategy was very much around, as a fifth plan one that of course has been quietly released and shelved, but was actually asking that whenever we do conduct research, there are 5 guiding principles. And of course, we all know we need more research. We have to do research for impact, but we have to support lived experience, collaboration and leadership, and talk to, as Amanda has, a whole of life and whole of community approach. Okay, so when we're talking about translation, This, I think, is probably the current state that Sophie spoke to, where this is a very common Bridgman and Davis policy cycle lens. Traditionally, the problem and construction, probably still overwhelmingly, is around a problematic brain. Amanda, you've all heard her, ask please don't look anymore at our brains. Probably the problem deficit or the locus of the gaze needs to be more around, thanks Elise, around the context in which we live. But of course that's what drives everything from then on in, including the knowledge production in the lived experience space. We talk very much about epistemic injustice a lot. And of course that flows through now to the policies and the programs that we have, and then of course the services that we have, which are overwhelmingly frontline medications and some kind of cognitive psychology. We do use the word biopsychosocial. I would suggest it's a trope. One of the reasons that we're unable to implement reform, I would suggest, is that we do go towards more performative responses. So whether it's the Royal Commission, the Productivity Commission, we talk about new structures, we talk about new processes, new ways of approaching the workforce. I'd probably suggest that what we need to be looking at for transformative change, which is what we're all after, is that we need to look at the mental models that the paradigms that we all approach mental health with. They generally sit within a medicalised understanding. This was an analysis done by Professor Sharon Friel at ANU, talking about very much the structural ideological waters in which we are all either inhabiting or swimming through in our health system. And that, of course, leads to a lot of antagonism and discourse. So we have people currently occupying those positions of power. We have people with lived experience coming from an emancipatory perspective, challenging all of these powers. So this comes from Danius Puris. You'd all be familiar with the work of the United Nations and more recently the World Health Organization. Announcing that we need to move away from chemical imbalances towards power imbalances and so on. And there was a discourse analysis that was done after his series of pronouncements indicating that, of course, all of the existing power holders are very, very challenged by these experiences. So from a lived experience perspective, we say that the brain is not the problematic bit, it's the environment. We think we should be looking much more at the social determinants. We know that we need to be actually bringing forward social solutions and social interventions, and that actually we should be providing services that are rights-based, healing, and about recovering citizenship. This has been going on for a very, very long time, since deinstitutionalisation. There was a hunger strike 20 years ago, challenging the knowledge base that current services sit on, challenging that it was biologically based and asking for, we haven't changed, housing, not Haldol. This has been picked up in recent years, and so this is the lived experience movement very much riding on this, that we need to be talking about social. So the family perspective that we now come from, we are not mini-me clinicians anymore, we are family members. And we are reclaiming our citizenship as well and standing shoulder to shoulder with people with lived experience who have been so profoundly harmed by the system as it stands. Very, very recently, this piece was done only a couple of months ago, identifying the family priorities for research. We also want the family lived experience to be heard in the same way that we're asking for experiential understandings of hearing voices to be heard. We have significant questions about our identity, a lot of resistance towards being positioned by the system in a responsibilising way as mini-me clinicians. We actually think we have a different identity, much more aligned to recovery of citizenship and relational recovery to inhabit. We also see that our rights have been breached. We're rights holders, our social, economic and cultural rights in particular, particularly excluded from the workforce, but also particularly a long way to go in terms of research participants and the lived experience workforce. So we know that, generally speaking, there's a lot more consumers as lived experience workforce members than family members. And of course, we need to develop those pathways and capacity building and growing that evidence base around what is constituted in terms of a family experience of distress. But we do know that the current system, the medical model, actually places an incredible burden on families in terms of trying to hold what they've been told by the dominant discourse, that this is a biological disease, but reconciling that with the person that they know and love, and trying to maintain a relationship that is mutual and authentic and a family relationship at the same time. So there's significant harm done to families. We also know the research is very clear around this now with particularly psychosis, that actually the messaging around biology is increasing social distance for people, including families who are often one of the major sources, along with the mental health system workforce, as sources of stigma. But that's what takes the headline. So this was in The Age 2 weeks ago maybe, that there is now a new drug. And it's interesting that this is what carries into the papers, not the previous bit of research actually about the lack of efficacy of the current systems. Designing a new drug that is going to cure a dopamine imbalance was the gist of it. So what we're asking for in summary, and I'm sorry, look, I've gone over a list, in terms of research is two things, a change in content and change in process. So process number one, develop some co-production skills, and I'm sure Michelle will talk to some of that. Become conceptually competent, understand there are different ways of understanding things, become reflective, become open to challenge, understand unconscious bias, epistemic injustice, intersectionality, become allies, do the work, and of course engage with people with lived experience who challenge you. So not the fawners, not the slipstreamers, not the people that say yes, you're wonderful, the people that challenge you. In terms of content, lose the clinical supremacy. It's not justified. Adopt conceptual humility, as I heard Barry start to lean into. Align with equity and human rights principles, and acknowledge context. Thank you.